In multiple myeloma, it almost has been a badge of honor to be conservative. So when I was in training, the mantra was you don't want to treat too early. And that was partly because very old studies have shown that there was no improvement for patients. But now that we have better agents, people are asking, are we treating sometimes too late? And that applies both at the time of progression from smoldering or MGUS, but also at the time of progression or relapse post-initial therapy. And I think this is a bit confusing because people can interpret relapse in many ways. And even though there's international guidelines that have been developed, such as those of the International Myeloma Working Group, still at the end of the day, it's just an N of 1, it's a decision we make at the bedside. I think most people feel clearly in need of treatment if the patient has symptomatic relapse. So if someone has hypercalcemia, if someone has anemia, that patient needs treatment. What I think is less clear is what to do when there's biochemical relapse. There are some patients who have a minute increase, for instance, in their free light chains. And even then, I know there can be discrepant opinions with some patients actually being observed and some physicians being very uncomfortable and immediately wanting to provide the patient with the best therapy. I think the step in between those two extremes, that is that a biochemical relapse that seems to be progressing. I think more and more people agree that that's something that should be treated. Now, to confirm this, I went to a place where everyone is testing everything, and that is Twitter. So I put a poll out there to see what my myeloma colleagues would do. And what I found is the majority of them think that treatment should be started at the time of progressive biochemical relapse. A few of them said just biochemical relapse. And of course, everyone agrees that you should treat when it's aggressive, but many would say that may be too late. One of the arts of the proper treatment of myeloma patients is to consider the patient, the unique features of their myeloma, for instance, risk stratification, comorbidities that the patient might have, personal preferences and logistics such as the driving time to a treatment center, but also another important variable is tolerance to the previous line of therapy. And I think that makes a world of a difference in how we integrate all of this information to decide on future lines of therapy. And everyone is unique, and I know that's very much a cliche, but some patients will not tolerate well a certain class of drugs, and then we have to keep that in mind for subsequent therapy. Or a patient may have had a very serious side effect, so peripheral neuropathy, for instance, with bortezomib. I think everyone would agree that we have so many options that for those patients, bortezomib should be omitted from future therapy. But again, it's an integration of all of this information. So I tell my patients sometimes, managing myeloma is almost like flying a small plane. It's rarely one gauge, but it's a combination of all that information that allows you to present an option to the patient.
When somebody has relapsed multiple myeloma, you really, in my mind, have to take a personal approach. And there's many factors that you have to consider when you're going to select a regimen for the patient. One of the first things is it biochemical only progression, or are they symptomatic? If it's biochemical progression, you may actually be able to delay treatment for some period of time by watching them closely, making sure they have no new bone lesions and no new end organ effects. And you may be able to put therapy off for maybe 6 months or a year. However, if they have symptomatic disease, you obviously have to start right away. Also, the pace of progression is an important thing. If it's a really slow progression, I tend to use, I almost always use triplets, but I tend to use triplets that are perhaps better tolerated or more convenient. I think elotuzumab, lenalidomide, dexamethasone, very well tolerated regimen. I use it in a lot of patients that have a very slow progressive disease. Also ixazomib, lenalidomide, dexamethasone, or IRD. It's an all-oral regimen. It's a very convenient regimen. I tend to use that also in patients that have more of a slow progression. On the opposite spectrum is some patients can have very rapid progression, and they can double their M protein in 4 to 6 weeks, and they can also have cytopenias. For patients that have that fast and that rapid a progression, I often, in fact, use chemotherapy. That is the patient population that I will use infusional chemotherapy, like hyper-CVAD with VB and Velcade, or VD-PACE or D-PACE, some intensive chemotherapy regimen that in general for us is given first few days in the hospital, where I really need to knock down that rapidly progressive clone and try to get better recovery of their blood counts, etc., so they'll tolerate further therapy better. And then there's the intermediate, the patients that have kind of intermediate pace relapse. And in those, we have so many options. It's really great. So carfilzomib, lenalidomide, and dexamethasone, KRD is a common one for me. Daratumumab, lenalidomide, dexamethasone, DRD is a common. And if I use KRD, then I'll use daratumumab as the next regimen, and I'll often combine it with pomalidomide and dexamethasone. Vice versa, if I use daratumumab, lenalidomide, dexamethasone, my next one is going to be pomalidomide, carfilzomib, and dexamethasone. So we have so many agents now, we can really plan our next 2 or 3 regimens just as we go, which is really great. I think that's most of the strategies that I use. The other thing I want to mention briefly is just comorbidities. You always have to be worried about comorbidities. And a lot of the comorbidities, in fact, are from their prior therapy. Sometimes they have neuropathy. The neuropathy has come from their prior therapy. If they have significant neuropathy, I'm going to try to avoid drugs that can cause neuropathy. Certainly bortezomib causes neuropathy. Lenalidomide sometimes causes some neuropathy. If they really have severe neuropathy, I might choose carfilzomib and pomalidomide, which both have much less rates of neuropathy associated with them. Sometimes if somebody has a history of a DVT or a clot, I don't think we need to stay away from the IMiDs. If it's convenient to, or if I have another regimen, like a regimen carfilzomib, Cytoxan, and dexamethasone, it's one of my favorite regimens. That one, we don't have to worry too much about blood clotting. But if they do have a history of blood clotting, you just have to put them on a blood thinner and get them on the IMiD-based therapy, and that's okay. And then lastly, I'll just say with renal insufficiency, the take-home points for that is you really need to dose reduce the IMiD, specifically lenalidomide, if you're going to use lenalidomide. I don't typically dose reduce pomalidomide. I don't reduce carfilzomib in that setting. You just have to watch them very closely and watch their counts very closely.